Welcome to the Sports Science Dudes. I am your host, Dr. Jose Antonio, with my co-host, Dr. Tony Ricci. If you're a first-time listener, hit the subscribe button and like the show. You can find us on YouTube, Rumble, Spotify, and Apple Podcasts. Now, today we have two special guests, Doctors Natalia Sikaczowski and Dr. Raymond Butts. Natalia, she founded Symmetry Physical Therapy in 2014. It's crazy. We've known each other for more than a decade. That's nuts. Remember meeting you first at University of Miami.
That's right.
But you founded it with the fundamental belief that patients should be treated on an individual basis. Natalia believes patients should be given a diverse array of treatment modalities and techniques, along with progressive and varied exercises and manual intervention to ensure maximum recovery. This all-encompassing approach, along with Natalia's strong background in strength and conditioning, has led to Symmetry's successful treatment programs for patients looking to get back into sport, recover from injury, or beat chronic pain. And certainly at the age that Tony and I are on, we are chronically in pain. So this will help us. Now, Dr. Butts, he's got quite the CV. He graduated with honors from West Point with a Bachelor of Science in Human Factors Engineering and served in the 1st Armored Division. He was an Army officer in Bosnia, Kosovo, and Iraq. He also received a postgraduate international master's of neuroscience from the University of, I hope I'm saying this right, Tübingen, Germany, where he investigated central mediated aspects of chronic pain with magnetoencephalography and functional MRI. In addition, Dr. Butts completed his doctorate in physical therapy and a PhD in motor rehab from the University of South Carolina. Go Gamecocks. So
yeah,
let's welcome Natalia and Ray to the show. Good to have you guys.
thank you.
Thank you. Thank you so much for having us.
Now, pain is the theme today, right? So we published a study in my group. We weren't necessarily interested in pain per se, but we were dealing with delayed onset muscle soreness and how supplementation, exercise, et cetera, affected it. And I didn't really know anything about pain. So I went into the pain literature and I'm like, what the hell am I even reading? Pain. I'm like, how do you define pain? Is delayed onset muscle soreness pain the same as, wait, I wake up and my back is kind of in pain? Because I know that's not delayed onset muscle soreness. And then you have a wide variety of pains dealing with acute injury, chronic injury, yada, yada, yada. I felt like I was grabbing water because of the definition of pain. Now, Tony and I deal with a lot of, athletes and the pain they typically feel is delayed onset muscle soreness. But pain is a lot more complicated than that. So tell us your view of that.
Yeah, I mean, pain is an extremely broad topic. I mean, you could separate it into so many different categories, and the problem with pain is that it's also subjective. So, how one person describes or feels pain is completely, it can be completely different, from one person to the next. So, I don't know. I think when it comes to a rehab setting, it's important to understand that pain can be peripheral in nature, and it can also be central. And then that central pain, you could further divide into pain which is mediated at the level of the spine, where the nerves kind of exit, and more importantly, the pain nerves enter the central nervous system. And then you can also have a lot of central pain which occurs in the brain. So as you said before, a lot of my master's and PhD work was really to kind of make it so that the brain was able to change in a way which was conducive to less pain and an improvement of function. So, it's interesting how you always have this connection between brain pain, spine pain, which is collectively central pain, and then peripheral pain. And then that peripheral pain is, can even be divided further. You have the sympathetic pain, and then you can have pain that are associated with different structures, whether it's muscles or joints or whatever it is. But yeah, I mean, I think for the most part, we're in the business of being able to treat pain and at least get it so that patients are able to move their body in a way which is normal, and a way where it's pain-free, and they can do the things that they want to do and interact with the environment in a way that they did before whatever the problem it is that they have started. But pain is that's a tough one. It's a tough place to start, just because it's so many different things. I mean, there's a whole school of thought that there's a whole psychosocial component to pain as well, and that pain is really mediated in how you think about it in the brain. And if you can think about it differently, then somehow you can change, how pain is being delivered and how you perceive it. I mean, there's really a whole side of physical therapy that is specifically geared towards that. I'm not a huge fan of that camp. I am when it comes to very terrible chronic pain conditions like complex regional pain syndrome or fibromyalgia or phantom limb pain. But I think most of the things that we treat, it makes more sense to take more of a direct physiologic approach. And I think we recognize that we see the best outcomes when it comes to pain when we have a multidisciplinary approach, meaning if we can offer patients kind of the way that a physician would look at it, maybe the way a physical therapist would, add a little bit of traditional chiropractic, add a little bit of maybe what has traditionally been acupuncture, massage therapy, some dietitian or some diet work into the mix, and we can kind of put the pieces all together into a way that makes sense both temporally and physiologically. Then we can begin to change the patient's anatomy in a way which undoes the circuitry that is responsible for that pain. And I think that's really what we're trying to accomplish here at Symmetry. So, provide one-on-one patient care without any students, aides, techs, in a way where we have the time, in a way where we can really package all of those things. Really, you could say what's the greatest hits of what's evidence-based from all of the different conservative rehab professions that are out there, and put it underneath one house in order to drive better outcomes.
And I mean, to Ray's point, that's a big part of having that one-on-one time with patients, of being able to properly diagnose where that pain is coming from. Because, as we all agree, pain is very broad, but we need to make sure that we're truly looking at all of the different components of pain. So, is pain being generated a little bit more by the joint, by the muscle? Is it more movement based? We have to really be able to dive in and properly diagnose the patient, and then be able to implement the treatment modalities that we have, and all of the different ways that we're able to treat pain, through dry needling, manipulation, exercise, movement, neuromuscular reeducation, so that we're getting a really full rounded approach to address every component of that patient's pain, and being able to change it both peripherally and centrally, so that, we're just eliminating on all fronts as much as we can.
Can I ask, Tony, unless you have a question, I have a million and one questions.
Yeah, no, just a quick statement that, and then you go to the questions, Joey. Fascinating, though, the effort that you both are putting into such a global approach, right? It's hard, it's challenging, because people like to scale modalities, methods, or the way you treat, and this is only because it just makes things easier and you can mass produce it. But to consider so many factors and contributing factors that are producing the pain, it's admirable. And I'm sure it takes a lot of work, a lot of research. It's arduous at times. And the treatment protocols, have a lot of time and thought and effort. And it's neat to see, because it's been scaled, right? Throw some ice, throw some stem, maybe some dry needle, and again, it's in and out. So I'm glad to see the kind of effort that you're putting forth into finding out what it is, where it is, and what we can potentially do about it.
I mean, I'll give you a quick example. I mean, let's imagine that you have something wrong with the spine, right? So maybe you've got some of the joints of the spine are not right. So certainly you could fix those joints. You could fix the orthokinematic structures. You could use mobilization, or you could use manipulation in order to do it.
Right.
But if you only do that and you only address the orthokinematic component, I think you're going to end up a little bit short-sighted. And if you think about why, I mean, think about all of the muscles that insert onto the spine where those joints are. if those joints aren't right, then it's going to take those muscles, and now those muscles are going to continuously live in an improper position. Those muscles are now going to be too lengthened, too pulled, too stretched, too torqued, too compressed, too something, right? And if that happens, then those muscles are now living in an improper position, and they have to tell the central nervous system about that position, right? I mean, that happens naturally in order to protect the muscle. So if you think about, well, what is it that lives in muscles that tells our muscles where they are in space when they're too stretched or pulled or torqued? The answer to that question is really muscle spindles, right? The more that you stretch a muscle out, the more that muscle spindles begin to fire. And when they fire, they release type 1A and type 2 afferents, which go back to the spinal cord, and they do what they're supposed to do, which is to tell the alpha motor neurons that are responsible for that muscle to contract the muscle, which makes sense, right? If you have a muscle which is being too stretched or pulled or torqued, you would want to counter that by getting that muscle to contract, right, in order to reach some sort of a normalization. But now if you think about it, if you have a muscle which is now continuously living in an improper position, now it's continuously being too pulled or too stretched because the place that it attaches, the joint's not right, whatever facet joint that is. Well, now think about it. You continuously have muscle spindle activity, which continuously activates type 1A and type 2 afferents, which continuously activates alpha motor neurons. And now that muscle is being told to fire over and over and over again. And it creates a situation where now you have hypertonicity. Now the muscle is firing above and beyond what it should be firing if it were to be at rest. And now it gets to the point where that muscle fires so much over and over and over again, you reach a point where you have hypoxia. Now you don't have enough oxygen going to that muscle because the muscle is working too much. So now the muscle wants to tell the central nervous system, hey, we got a problem. What does it do? It releases factors of inflammation, factors like bradykinin, substance P, CGRP, various interleukin factors, which collectively creates a giant soup of crap. And that giant soup of crap drives the pH down and makes the environment inside the muscle more acidic, right? It's kind of the same thing that's happening with the DOMS, with the soreness, right? So now you've got this area of the muscle which is acidic, the pH is off. And the problem with that is now that pH begins to wreak havoc at the neuromuscular junction. What does it do? It breaks down an enzyme that lives there called acetylcholinesterase. The job of acetylcholinesterase is to take away the acetylcholine, right? If you can't take away the acetylcholine, now the acetylcholine, it begins to back up or get backlogged in the neuromuscular junction. The problem with that is that's the very chemical that the alpha motor neurons use in order to tell the muscles to fire.
Constant firing, right?
So now we have acetylcholine, which is sitting there. It can't be removed, right? And it builds and builds and builds. And now at the level of the neuromuscular junction, now we really have a problem because now the chemical is there to ensure that that muscle continues to fire, which, oh, by the way, is exactly the mechanism by which we get to trigger points. Right? The top nodule that is so painful that occurs in muscle, right? The parts of the muscles that feel angry and aggravated and pissed off, they're continuously firing where everything around it is soft and squishy and relaxed. That's exactly what's going on.
Trigger point.
Right? So, I mean, I want you to appreciate why it's important. Like, you can't just address the arthrokinematic structures because what about the soft tissue structures? You can't address the soft tissue structures without addressing the joints. So, I mean, right there, I mean, unless you're bringing those two pieces together, you're already going to be short-sighted. Right?
Best step-by-step description I've ever heard, Dr. Butts. Thank you. Really informative. Go on, Joey. I'm sorry. I don't want to interrupt your.
Well, no, I want to write a paper where eventually I could write that soup of crap. It was really quite a descriptor.
It was beautiful.
The military,
it was step by step, and I get it. Beautiful.
No, it's very descriptive. I actually have, this is a sort of a short sidebar based on some of the research I've done on delayed onset muscle soreness. And the hardcore physiologists, they'll make fun. I don't know if that's the right word, but let's say when we assess delayed onset muscle soreness, it's almost always just a visual analog scale. How sore do you feel? Well, I feel really sore. I don't feel sore at all. And sometimes we'll use an algometer, a pressure algometer. We'll push it on the muscle that's sore, and they'll tell us when they feel pain. But again, The hardcore physiologist would say, well, those are so indirect that are they even meaningful? And then we'll take blood markers of skeletal muscle damage, plasma, usually CK or myoglobin or whatnot. And we tend to find that they don't seem to relate to each other. Sometimes CK is high, but you don't feel pain. Sometimes you feel pain, but CK is not high. So I guess my question to you as clinicians, also as a pragmatic physiologist, I always say, well, if I don't feel sore, then I'm not sore. If I don't feel pain, then I don't feel pain. Wouldn't the visual analog scale or just the sensation of, hey, I'm sore or not sore be enough? Because I can't think of another way via research to assess pain.
So, yeah, I mean, it's accepted in the literature that via reliability studies that the visual analog score, and I think one step better than that would be the numeric pain rating score, right? That's usually how patients would subjectively measure their pain. And we know that we have a minimal clinically important difference if we have about a 2 out of 10, as what's established in the literature, a 2 out of 10 change, right? 2 out of 10 would be a change in an increase in pain. It would be like a pain which is detectable by the patient, or a reduction in 2 out of 10 would be a reduction in pain that would be meaningful to the patient, right? That's the very bare minimum that's required. But so that's accepted, and I think it's accepted as something which is reliable. It's very easy to measure. I think what the literature has really gone to or going to is kind of a way to measure more specific pain fibers. So you can measure like a delta pain, or you can measure C fiber pain more directly, right? So a delta, so if you think about it, you have different pain fibers, and the differences in those pain fibers really depends on how quickly that pain is being transmitted to the central nervous system. And that depends on whether you're talking about myelinated pain or unmyelinated pain, right? Myelinated pain obviously is quicker, unmyelinated would be slower. And then you get into, so a delta pain would be more myelinated, C fiber pain would be more unmyelinated, and then somewhere in between, we have more of like a beta pain. Anyway, the point is, a lot of the research is now beginning to look at the difference in the pain perception between A delta and C fiber pain, for example, right? So A delta pain it's the first perception of the patient's pain when they feel pain, right? So you could provide a cold pulse, a heat pulse, a pressure pulse, and the very first time that patient interprets that stimuli as being ouch, that's painful, that's A delta pain, right? Fast, myelinated, really quick, sucky pain, right? C fiber pain, on the other hand, is more like wind up pain. That's where I give you a stimulus, but it doesn't really hurt. I give you another stimulus, that doesn't hurt either. I give you another one, that doesn't hurt. But if I hit it, then eventually those stimuli begin to wind up into something which is more painful, right? And that's really interesting, because what we're starting to see in the literature is that it seems that a lot of the things that we do, that we can really use being able to change a delta pain. And if we can, let me say that differently. We can use the modalities that we have, whether it's spinal manipulation or dry needling or other things that we do, in order to provoke a delta stimuli, right? It's kind of like you provoke pain, which is good, right? Yes, it hurts the patient, it's uncomfortable, but therapeutically it makes sense. Why does it make sense? Because what we're starting to see is that if we can provoke a delta pain, that we can use that pain in order to change central pain, which is more wind up in nature, right? Which is more of like your pain sensitivity, right? It's that slow, lingering, burning, pulsing, annoying, always there in the background sort of pain. That sort of pain is typically associated more with central mediated chronic pain. So if we can change the perception of pain centrally, i.e. C fiber pain, right? We can do that by provoking a delta pain in the clinic, right? And that's kind of the pain that we're trying to provoke when we use certain things like manipulation or mobilization or dry needling. It's the reason why we try to manually stimulate the needles when we do dry needling, either manually or electrically, because we're always trying to change the synapses, to change the route, to change the network that pain uses in order to travel from the periphery where it hurts to the brain. If we can rewire that by changing the perception of C fiber slow pain by using A delta pain, then we start to change the way that patient perceives pain over time. Does that make sense?
Yeah, it's fascinating. So we're kind of going from non-myelinated and trying to go into myelinated. Is that part of what we're trying to do, or?
We're trying to use the patient's first perception of myelinated fast pain
Right.
to ultimately rewire
That,
this patient's sensitivity, which is truly slow C fiber pain.
and usually non-myelinated, am I right? Or?
That's correct.
Right.
That's right. Yeah.
Yeah. So yeah, that is, excuse my language, but that's friggin' cool. Go on, Joey.
Yeah.
Fascinating.
It is.
Well, I know
yeah.
Tony and I spoke just briefly about he'd had dry needling done to him, and I want to touch on that after this question, sort of a personal question. Many years ago, when I used to be very much a gym rat and loved to lift, I would typically pull my back probably 2 or 3 times a year, and it was almost always doing the same exercise. It was doing standing curls, and it wasn't like I was super strong, but 2 or 3 times a year, I yanked my back. And one time it got so bad that I had a hard time getting out of bed. Now, my father was a physician. He was an internal medicine doctor. He was an MD. So what did he do? He's like, hey, here's some drugs to take. Maybe it'll help your pain. I took some. It didn't really help. It's like, damn, it really hurt. So I went to, I think he sent me to a physical therapist. They did the typical, this is like 1980 something. Ultrasound, whatever they traditionally did back then. I'm like, damn, it still hurts. And I asked my father, I'm like, what do you think of chiropractors? I don't know anything about them, never been to them. He's like, oh, they're a bunch of quacks. I'm like, huh. Well, you know what? My back still hurts, so I'm going to go see one. Went to this chiropractor in Dallas, and he adjusted my cervical spine, thoracic, lumbar, and I was pain-free. And I was like, holy shit, I don't even know what you did. But I know I had pain before when I walked in. I have no pain when I walked out. And that was after trying all the traditional, the drugs, the therapy. Mechanistically, what the hell was going on? I mean, it wasn't just, he manipulated my entire spine. And I was like, holy shit, whatever you did works because I feel no pain.
Mm-hmm. Yeah, I think to your point, one of the main things that we are redefining in the physical therapy profession is, the ice, the heat, the ultrasound, most of that is really thrown out the window with us. So
Thank you, because that shit didn't work for me.
Yeah. Right. We're able to spend the time with the patient and address the foundational issues that are really going on. So addressing the joint mechanics, addressing if there is an issue with the information that the patient is receiving from the joint, from the muscle, and then fix the movement patterns that either got them there in the first place or have contributed through the evaluative process. It's not only addressing the acute pain and addressing the local inflammation, but we're trying to look at what got this person here to begin with. Is there an actual asymmetry of range of motion somewhere? Oftentimes in the low back, you'll see patients who have a lot of limitation in hip internal rotation. So if we don't address hip internal rotation, the back continues to hurt. If you spend all your time on the back and you don't address other things happening, then really, all you're doing is kind of chasing your tail and addressing what the symptoms are instead of the foundational problem. So, there's many things that go into the evaluative process. As far as the specific mechanics of what we do during a spine manipulation, Ray taught this for 10 years, so I'll let him go into it.
I got it. Yeah. No, I'd love to hear this because no one's ever really explained it to me.
So I guess I just want to make sure that I answer the question the right way. So are you asking what is happening when you manipulate the spine in terms of the sounds, or are you asking why it is that you felt better?
The second one, it's go from I feel pain. I'm like, doc, it hurts. You know, my low back hurts. Maybe a little bit in the neck. My thoracic spine seems to be fine. It's always either neck or lumbar. And they manipulate me, and it does something where pain diminishes, and it doesn't diminish a
Sure.
little bit. It diminishes a lot, which I'm like,
It
this
can.
is really weird.
Mhm.
Yeah, so I mean, the chiropractors will often say that you have these facet joints which connect all the different vertebrae in the spine. And the way that they connect is via superior and inferior articulating processes. And if those, they would say that those joints, based on your activity or what you did, that those joints are now out of place. They would call it a subluxation. And that subluxation, they would say it changes the neural outflow from the central nervous system to the periphery and then causes a whole host of different problems. We would argue that we don't really know that that joint is out of place. Like we don't have special tests that are good enough to tell us what's wrong with that joint. All we really know is that the facet joints are not right. So are the facet joints out of place? Maybe. Are they forward rotated, back rotated, in flared, out flared, up flared, down? All of that is possible. Maybe those facet joints, based on what you did, are now fixated. Maybe they're stuck, and maybe they're not out of place. Maybe they're stuck in place and they need to move. Right?
Okay.
And not only would the physical therapy profession say that, but the osteopathic profession would say the same. Like we just don't know what's wrong with the joints, but what we do know is that if we can move the spine in a way which is meaningful, and we can get the spine to make sounds, and we can get those joints to make those sounds, which there's a bunch of different theories as to where the sounds come from. I think the leading theory is still the release of gas inside the capsules of those joints, but neither here nor there. That's the theory of Unsworth, and I believe it was 1972. Then whatever the joint needs to do, or whatever the joints need to do, it's going to do that, right? So it turns out that we don't really know reliably what the problem is, and we don't really know a specific technique which technically matches the problem. It's kind of like we know we can say that there's a facet joint problem. We could choose a technique that creates sounds in those facet joints, and then whatever the body needs to do, it's going to need to do that. Why you immediately feel better? That's an interesting question, because there's a bit of a debate as to whether, what are we moving the bones? Are we changing the position of those bones, the vertebrae? And it's very difficult to say that we are unless you were to look at the extreme cases in the literature. And I would say
Mhm.
the most extreme case in the literature would be scoliosis, right? Well, if you look at patients that have scoliosis where they have a lot of movement of the spine and you manipulate that spine, you can actually measure a change in where the bones sit before and after the manipulation. So you can say that, hey, it certainly seems like the bones are moving, right? I think in a normal patient, it is likely the case that those bones are moving. We just don't have tests that are reliable enough to show us that small amount of movement which is occurring, right? To demonstrate that that movement has actually occurred. Chances are, though, it has.
Right.
What I think is making the biggest difference when it comes to patients pre to post manipulation, and why patients feel so good when they leave the chiropractor, and why they feel even better when they leave the physical therapist. That was a joke, but is when you manipulate the facet joints, you actually activate the mechanoreceptors and the proprioceptors in the joint structures, and then all of the different ligaments and the tendons and all the surrounding structures that are associated with that joint. When you activate those mechanoreceptors then feed back to the spine again. And what's interesting is the number one thing that they do is mechanoreceptors inhibit the alpha motor neurons of the muscles that are associated with those joints. So if you think
They're
about
relaxing.
yeah.
Yeah.
So instead of, well, like we talked about before, where we upregulate the alpha motor neurons and we
Right.
start to get this hypoxia and trigger point formation, when you manipulate the facet joints, you activate the mechanoreceptors, you actually quiet the alpha motor neuron.
Right.
which were
Wow.
too noisy before, right? Which is the reason why you can feel the paraspinal muscles before and after the manipulation. You feel them before. They're angry, they're aggravated, they're constantly firing, they're overworking. You manipulate the spine and now you feel it again. Now they're soft and squishy and relaxed because we essentially just activated the right nerves to quiet the alpha motor neurons, which were driving the hypertonicity.
Wow.
That's why you had this immediate reduction in, or you have that immediate euphoria after the manipulation.
Yeah,
What
I don't know if I have smushy paraspinals, Tony. Maybe
No,
a little.
I tell you though, this is
Couple.
great. This is so cool because it makes so much sense, and hearing this breakdown is fascinating. And,
Let me make it.
you're sequentially explaining what's going wrong, and it really it just, I think it elucidates it well for all of us. Really cool, really cool.
Thank you for saying that. I'll just say one more thing about it, which I think is really interesting, and I like to talk to patients a lot about. We get a lot of patients that come in the clinic and they've got disc pathology, right? So, when you first described your injury, I thought for sure, I mean, based on what you described, you got a whole lot of weight, you're doing curls, you're in a moment of flexion with your spine. I mean, that's a classic case where you would start to have a bulging or a herniated disc, right? So we get a lot of patients that come in the clinic, maybe they blew out L4, 5, 5, 1, something like that. They got a lot of low back pain. And you think, well, what are we going to do with that patient? Well, this is a classic case where putting the pieces together in a way that physiologically makes sense gets you to better outcomes, because certainly we would want to start by using a lot of physical therapy techniques. We would use like McKenzie progression, right? And we would do that in order to do extension-based work, which is opposite of the mechanism of injury. So in the neck, that's right, with the retractions. In the lumbar spine, we're doing the prone press-ups, right?
Yep.
A lot of different reasons why we would do that. In theory, the idea would be that by going into extension, we put a lot more pressure on the posterior aspect of the disc and start to move the annulus forward again. Great theory, never been shown in the research though, but still a great theory. Another big one is that we're doing that in order to move more water back into the intervertebral discs. That's what Dr. Paul Beatty showed out of the University of South Carolina about 10 years ago. Really shows moving water back into the discs. It increases the health of those discs and makes them much bigger, which makes more room for the nerves. And then there's a huge argument to be made that when you're doing that McKenzie, that you're actually taking nerves which are in a position of being stretched and taut and pissed off, right? They're fired up. And you can take those nerves, you can put them into a slackened position, which takes the inflammation out, right? And as you take the inflammation out of those nerves, then we start to centralize the symptoms, right? From the legs or the arms back into the spine. So lots of different reasons why you would use McKenzie to treat the disc, right? But what you find with those patients is as you treat them, they get better, but usually it's not the McKenzie which is enough to, maybe over time, but if you can add other things into the McKenzie, you start to get a better result. What would I add? Well, what's interesting is that if you look at the neural innervation of the disc, right, it's really the medial branch of the dorsal rami, which is interesting because if you look at what other structures that nerve innervates, it actually not only innervates the disc, but it innervates some of the other really big dog structures at every single level. What structures am I talking about? Well, the deep multifidus, which is the number one stabilizing muscle of the spine, right? And that's the nerve that innervates the facet joints, right? And so you start to read about something called dorsal rami syndrome in the literature. And what they mean by that is you have a problem with any of the structures that are innervated by the medial branch of the dorsal rami, i.e. the intervertebral disc, then it has a negative relationship on the other structures that are innervated by the same nerve. That's why you have patients which have a disc problem. And as a result of that disc problem, now we end up with fat infiltration and we end up with atrophy of the stabilizing muscles of the spine. And we have facet problems. It started off being a disc thing, but now we have muscle problems and we have joint problems, right? And it works the same way. You start off with a facet problem, like what you were talking about, where you crack it, right? But you end up with that facet problem that could have a negative relationship on the disc and the deep stabilizing muscles of the spine. So the way that we think about it is, well, what if we could try to treat all of the major structures that are innervated by that nerve? In other words, let's use the McKenzie to treat the disc. Let's use the manipulation to treat the facet joints. And let's use the dry needling to treat the deep multifidus in the spine where the problem is. And now I'm hitting 3 structures. If I can do that and I could reset the medial branch of the dorsal rami, I find that those patients get better in about half the time, right? It's another example why it's not good enough to just look at one thing. Like it has to be a global approach where you've got to be able to treat all of the different parts of the problem and be able to package it in a way that physiologically makes sense in order to get to a better outcome. And I think this is really important for physical therapy now that I'm on my soapbox, because I'll tell you, the reason
Good question when you're there,
Keep going, keep going.
I'll just say this and I'll shut up. But I mean, I think one of the biggest problems of physical therapy is we're not efficient. I think patients they don't want to feel better in 3 months. They don't want to feel better in 2 months. They want to feel better on Saturday.
Yep.
You know what I mean? They got a 5K coming up. They got a 10K coming up. They want to be in a tennis tournament. You know what I'm saying?
Yeah.
Like it's a problem because usually physical therapy is the last resort because the patients think that it's going to be this life-altering, changing 3-month miserable experience. And in some cases, yes, okay, it takes time. But if we could just reevaluate the physiology of what you guys are talking about, which is the pain, and we could put it together and think about it in a different way, you know what I mean? Then we should be the standard of conservative care, not.
It's great that you mentioned that, Dr. Butts, because I don't know how many times I've been told by not just competitive athletes, but just recreational athletes. They're like, I'm not going to that damn PT for the next 8 to 10 weeks. Why the hell am I going to do that? And I'm like, well, you're right. I wouldn't have the patience either. So I'm glad you're pushing the envelope here because you're right. It's people want to be relieved of pain now. They don't want to wait, hey, and I could say, well, in 3 to 4 months, it might resolve itself. So why should I, go to this clinic that it seems like it's more of a factory. People go in, they do the same old shit. People come out and it's like, everyone's doing the same old shit in there. Yeah. But anyways, I because we're limited with time, I want to get to the dry needling. And Tony, you have you had experience with it. I've never had experience with dry needling. So tell us a little bit about that. And then I want Natalia or Ray to comment.
Yeah, well, just I'm fascinating anyway, and that I have done the dry needling, but just a simple yes or no. You talked about a sequence of disc. I want to save time for you guys because I'm loving this. Disc, maybe facet, right? And then what
was it muscles?
The muscle, yes.
Multifidus.
Can that all be done is that done simultaneously or is that done in order? In better words, you have to go to 1, 2, or 3 first. Is there an order to that? Or in one session, they could all be addressed to an extent?
So yeah, the exercises, the McKenzie is more for the disc, the manipulation is more for the facet, and the dry needling is more for the deep stabilizers of the spine. Right. So everything is addressed in one session.
Okay.
Within 15 minutes, you can address it all.
Okay, great. That's awesome. I didn't know if they were sequential, but awesome.
Yes,
go on, Dr. Butts.
Well, I mean, it's important to point out, we wouldn't necessarily do all of those things in a patient that is acute, right?
Right,
so You got a fresh disc, right? I have no business sticking needles in you.
Yeah.
Okay, you can't take a problem which is already pissed off and inflamed, and what am I going to make it more pissed off, right? I got to calm it down first. But in a subacute or chronic case, I would say bring it up.
Yeah, awesome. No, just limited experience. I mean, I have a friend who's a physical therapist. I think he's very good. He does good work. He's very, multifaceted approach. I'm sure some of the things you do, maybe not all, of course, but nevertheless, I use McKenzie technique with great success in my neck because I'll shut down the entire side where I can't put a shirt on and I can't breathe. But I had walked into his clinic one day and he coordinated in concert, he used stim with the dry needling. And I can just say, listen, I wasn't permanently cured by that, but boy, there was a significant reduction in pain and increased mobility immediately. So the limited experience I have with it, I would assume if it's practiced properly, it's pretty good, a really good procedure. Dry needling, that is.
Agreed.
Mm-hmm.
Yeah.
Yeah, I mean, dry needling is an interesting topic because I think in the world of physical therapy, it's defined in lots of different ways. And
Okay.
we continue to battle ourselves in the profession, and in some cases it's used in a more restrictive way, where we call it intermuscular trigger point dry needling, right? So we see a lot of physical therapists that stick needles in, and they piston the needle in and out of the muscle tissue in order to deactivate the trigger points. And I'll be the first to tell you guys, like, that's not wrong, right? And it matches the physiology that we talked about before. When you do that, right, why are you doing it? You're doing it in order to elicit something called a localized twitch response. Well, what's a localized twitch response? I mean, essentially what you're doing there is you're 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 stimulating the tissue in a way where you cause a little bit of pain, which feeds back to the spine. It activates the neurons which live in the dorsal horn of the gray matter of the spinal cord, because that's where pain information is delivered.
Mhm.
And the dorsal horn neurons, right, the pain neurons, they talk to the motor neurons, which are in the ventral horn of the gray matter of the spinal cord, right? So now you have pain neurons, which activate the alpha motor neurons, right? And now pain is now stimulating alpha motor neurons to fire. And now the alpha motor neuron is sending the stimulation down to the neuromuscular junction. But based on our conversation before, what's the problem with that patient's neuromuscular junction? They've got a backlog of acetylcholine, remember? Remember we talked about that? You got all this acetylcholine just hanging out there. It's building and building and building. And we got a crap load of acetylcholine right in the neuromuscular junction. And now you just fired the alpha motor neuron responsible for that neuromuscular junction. What's going to happen, right? All of a sudden, you have 10 times the acetylcholine. Boom, you hit the neuromuscular junction and it blows up, right? That blowing up of the acetylcholine in the neuromuscular junction is the localized twitch response. In fact, you can continue to take that needle and put it in and out of the muscle, and it's going to twitch and twitch and twitch again until there ain't no acetylcholine left.
You're depleting the acetylcholine then.
Right. And why would that be bad? That's not bad. It's not
Right.
wrong. And that definitely, it combats the trigger points in the muscle.
Yes.
What I would say to you, though, is that that is one aspect of what we do, but it's just a very small aspect.
Ooh,
At the end of the day, what makes dry needling work is really mechanotransduction. It's really the same premise as what's thought to make acupuncture work. I mean, if you think about it, it's the same needles, it's the same sort of techniques. The premise or the theoretical construct might be different, but what really changes the tissue when you needle a patient is not the pistoning of the needle. It's leaving the needle in the patient's body in situ for a period of time. What's evidence-based is leaving needles in the patient's body for at least 8 minutes, but no more than 30 minutes, in order to maximize the physiologic effect. And here's how you get the mechanotransduction, right? You put the needle in. I don't know if you can see this, maybe up here. Okay? And the idea is now we wind the needle to different extents, right? And it depends on how sensitive the patient is. But you can imagine that maybe it's easier showing me. If I put the needle in and I wind the needle, then you can see how I change the tissue all around, right?
Yep.
I'm pulling on the tissue, right? In the very same way that you would put a fork into a bowl of spaghetti and you would wind the spaghetti around the fork. You're essentially winding collagen fibers or connective tissue, like the same collagen fibers that make up the fascial planes of the body. You're winding them around the needle, right? And you're doing that in order to pull or to change the shape of the cells which live in that tissue. Why would you want to do that? Well, you're changing the shape of all those cells, because if I can change their shape, then mechanically I can begin to talk to those cells. Because if I can change their shape, I can tell them to turn the DNA or the RNA on in those cells, and I can get those cells to make stuff. What do we want to make? I want to make opioids. I'd like to make some adenosine. I'd like to make enzymes and proteins and raw materials that give me a better reparative response, right? It's one thing to just to push the tissue to drive the pain down. That's good, that's great, but it's a completely separate thing. If I can drive a better reparative response, if I can make the tissue look like it looked before the problem was there,
right?
That's not just short-term solutions, that's long-term results. Now, here's the beauty, because yeah, it's great if I could wind the tissue and I can mechanically talk to the cells one time. What would make that better is if I could continuously talk to those cells over maybe 20 to 30 minutes. And that's the reason for the electricity. So think about it. If I put the needle in and I wind the needle
and I put another needle in and I wind this needle. And now I got multiple needles which are left in the patient's body. Right? And now I hook it up to electric. And now I take the needle, which is now wound in the tissue, and I do this. Every second or 2 seconds, right? That is the equivalent of me telling the cells, hey, I want you to do this. I want you to make this. And I tell them now the same instructions every 1 or 2 seconds over and over and over again. You see what I'm saying?
Yeah, that's cool.
So,
Wow.
Like a Family Guy episode.
in this way, I can exaggerate the physiologic change that I'm trying to drive. Like one of the enzymes which is created, this will drive home the point nicely, is something called Row-and-Rack kinases. When you mechanically stimulate the tissue and you change the shape of the cells, you get the cells to make Row-and-Rack kinases, right?
Okay.
What do Row-and-Rack kinases do? Those enzymes break down the actin cytoskeleton of cells. Every cell has a particular shape because of the actin cytoskeleton that gives the cell that shape.
Right.
When you make Row-and-Rack kinases by mechanically stimulating the tissue and changing the shape of the cells, you cause them to make Row-and-Rack kinases, which breaks down the actin cytoskeleton. If you take away the skeleton of the cell, you essentially start to change the shape of the cells.
Right.
And by changing the shape of the cells, you remodel the tissue. If I could remodel the tissue in a way which is physiologically appropriate, that's game over.
Right.
You see what I'm saying?
That is fascinating.
So I want people to understand that when it comes to dry needling, like there's so much more that's going on. If you just make it your business to understand the physiology, there's so much opportunity there of being able to treat the tissue and change the physiology from the problem, which is inside the body. It's usually the stuff that we can't get to with our hands or with manual techniques. And if we can put that together with the manual therapy and all the rest, I think we get to better. It's just an example of why I think dry needling is so powerful, and there's just so many things that are happening. If you start to tease out what's going on, I have a paper, not to plug my own paper, but
plug your paper. We like papers.
Yeah, we
do.
I'm learning. I want to learn more. So please plug the paper.
I have an 18-page review paper, which really describes in detail all of the different physiologic mechanisms that are responsible for dry needling.
This will be published where?
Well, it is. It was published a couple of years ago.
Okay.
I sent it to you guys, but it's nice. It's 18 pages, as I said, but like just to point out, like 2 of those 18 pages are related to trigger points.
Okay.
16 of those pages are the rest of the story, right? You know, I mean, it's like there's just so much going on, and it's such a meaningful modality because of all of the rest of the story.
Not to mention too, when you do the dry needling with trigger points, some people don't like dry needling because they will have the experience where you go in and you piston and you piston and you piston, you're bringing that needle in and out, and it makes the patient sore as heck. And you're not really fixing the foundational problem of remodeling the tissue. So instead of doing a pistoning technique, putting the needles in, winding them up, hooking them up to electrical stim, the patient is not going to have the same type of soreness either. So, you know, for patients who have had dry needling in the past, it's really important to define, well, exactly what happened before, because that might not be, you know, how another approach to doing dry needling, which addresses more of the foundational issues of the physiology.
Now we're limited with time, so I want to get to one last subject, okay? And this applies not just to physical therapy, but I've mostly got this information from the bodybuilding world, mainly exercise physiologists that study bodybuilding, blood flow restriction training. What is the role of that within the PT realm? Because I know in the exercise realm, people like to use it as sort of a different way to induce hypertrophy. Now, I don't know if you guys are trying to induce hypertrophy, but you're doing something with BFR. So tell the audience.
Yeah. So, I mean, BFR is wonderful. BFR is standing for blood flow restriction. What you see a lot in the gym is people who are taking these elastic bands or these belts and they're cranking them on their arms and, you know, not really measuring how much occlusion they have with the vessels. How BFR is supposed to be used is 80% occlusion rate for the lower extremity, 50% occlusion rate for the upper extremity. And you can exercise a patient or anyone at 20 to 30% of their 1 rep max,
Mhm.
and you're getting the same benefits as if they exercised at 80% of their 1 rep max. So the strength gains that you're getting with BFR, of course, you still need to, take into consideration the integrity of the tissue, if there's any surgical repair, if there's anything else going on that would prevent you from doing that. But we're able to strength train patients at such a low, rep weight, and put the same strength gains on them as if they were lifting quite heavy. So,
Right.
Where that is important, I mean, almost every single patient can benefit from it. You have
Mhm.
pre-surgical patients who are trying to, get rid of the atrophy and put some muscle on prior to going into surgery. You have post-surgical patients. You have patients that just have muscle inhibition, or maybe they have an issue with a joint or something else going on where they're not able to load heavy. But how powerful is that? It should be in every single practice that you're able to take these patients and load them so light and get the exact same benefits. It's not better than training at 80% of your 1 rep max, but what the literature has shown is that you're getting the same rate of return as if you're training at 80% of your 1 rep max.
Yeah, and you certainly don't have to use heavy loads, which is what scares a lot of people.
Yeah.
Right. I mean, you're using very lightweight. You're still getting a lot of burn while you're doing the movement, and you're doing between 15 to 30 reps of the movement, depending on where you are in your range. But you start with 30 reps, generally go down to 15, 15, 15, doing 3 to 4 sets. And to be able to take that and implement it both in a rehab setting and in a strength and conditioning setting, it's pretty powerful.
Tony, you look like you have a question before we wrap up.
Yeah, no, just quickly, like some of the mechanisms are we, so how's that happening? Just quickly, Natalia, are we impacting neural drive? Are we getting more motor units involved? Is it the hypoxia that is, like, what are some of the things that might be driving that?
So through the hypoxic state of basically occluding the vessels, you're creating a very similar environment. If you think about heavy loading, what
Mhm.
happens? Well, you're compressing all of the vasculature, you're
Right.
increasing blood pressure locally, right? And you're creating an environment for hypertrophy to happen. Well, you're mimicking that exact same environment with the occlusion therapy with the bands, right? That you're putting proximally, close to the joint, either on the upper arm by the shoulder or on the upper thigh. So you're basically mimicking and simulating the exact same environment that you would be in traditional strength training.
Got it. Great.
Final words from Dr. Butts. You can get on.
I think what Natalia said is yeah, I mean that's accurate. I think there's also something to be said for a lot of the things that we treat. You can make the argument that the body doesn't heal itself as well as it should because there is the absence of adequate blood flow,
Mhm.
right? So, I mean, you see that in like meniscus, or you see other problems where, if we can just magnify the increase in the movement of blood into that area, then we can promote better healing. I mean, if you think about it, that is the very premise of what's going on with the PRP injections, right?
Right.
I mean, you take the patient's blood, you spin it down, you get the most important factors of healing with the platelets, and then you inject it right at that spot, right? I oftentimes will say to patients, and I think this goes for both blood flow restriction and I think you could argue cupping, right? That you're kind of blocking blood from going to that area for a period of time, depriving the part of the body with as much blood as it's used to. You get the body to panic, like, holy crap, I'm not getting enough blood, right? And then all of a sudden you take the blood cuff off, or you take the cup off. And then, yeah, in an overcompensation strategy, the body wants to fix the problem right now. So it sends excessively more blood to that area. And so I kind of say to some of the patients, like, sometimes I wonder if it's just a poor man's PRP,
Mm.
right? Like, aren't we really tricking the body in order to send more blood to the place where I want more blood in the first place, right? And it's an interesting premise.
Natalia, where can people in the audience find out more about Symmetry Physical Therapy? tell us where we can find you.
So you can find us on our website at www.ptmiami.com. So as in physicaltherapymiami.com. We have tons of pages on our website going through the physiology behind dry needling, behind manipulation, behind blood flow restriction. We really, really find it powerful to empower our patients to advocate for themselves. We have an entire page dedicated to research, which has a lot of published articles that came out of Symmetry, many articles that were published by Dr. Butts, and other articles as well, that people can go and they can read the research and they can read the literature behind what it is that we do. You know, it's really important that patients understand the methods behind why we practice the way that we do.
Yeah.
You know, it's a very vulnerable thing to be injured. And when you have an injury, when you have pain, a lot of people's worlds get turned upside down. You know, it's not only a physical thing. You're oftentimes taken out of your community. You're oftentimes not exercising as much as you want. It affects many areas of your entire body. So being able to feel on your own empowered with the literature behind you, with knowing more about the techniques and knowing that there's a way that you do not need to live in pain, however it is, big or small, you know, I think that that's a really important component to patients going through any type of injury or discomfort. You know,
Yeah.
It doesn't have to be that way.
And thinking about rehab in this way, it's really given us an opportunity to treat a whole bunch of other patient types and with excellent outcomes that maybe are not being seen by typical physical therapists. For example, we're really one of the very first headache specialty clinics in Miami. So we're seeing patients for migraines, tension type headaches, cervicogenic headaches. We see a lot of post-concussion, a lot of TMJ, and we're the very first clinic in Miami that has started an initiative on the rehab for regenerative medicine. So, you know, the rehab that patients should be getting after a PRP injection, after a stem cell injection. You know, what's different about, you know, fat stem cells versus BMAC or mesenchymal stem cell. You know, I mean, this is getting really, really popular, and no one's really had the conversation about, you know, what happens after all of that stuff. And the evidence in the literature is really limited. So we've really tried to take a deep dive into the literature and look at the physiology of all the things that we do, and then determine like how that stuff fits with, well, how do we maintain the environment whereby stem cells can live and proliferate and differentiate and call other stem cells to the area? How can we get the best maximum effect from the PRP injection or a steroid injection? Yes, I mean, we've really been able to do some special things. And I think that I want to let your audience know that if they've got something going on, and you know, maybe just give a call, and I'd at least love to have the conversation and see if we can help.
And to your,
Definitely. I think I just found you. Am I right on Instagram as well? Symmetry PT Miami. Is that you?
yeah, that's the other way. We have some pretty informative videos and articles. We also link to our blog post, which is on the website as well. So we try and go
Great.
through some of the physiology behind things. We have our YouTube channel as well. So if you look up Symmetry Physical Therapy Miami, there are active exercises, different nerve glides, things that people can do at home as well to help to facilitate their own healing.
No, this has been absolutely fascinating. I love that you guys are embracing. A lot of clinicians don't embrace the science as much. They go to school, they do a treatment because you come in with symptoms versus understanding the underlying mechanisms. I think that's great. And you know, I always say, when you're in pain, there's only one thing you think about: getting rid of pain. Everything else doesn't matter. So you guys are doing a great service. This has been great. Dr. Ricci, Dr. Sikaczowski, and Dr. Butts, this has been fascinating. Thank you again for appearing on the Sports Science Dudes. This has been an absolutely great show. Thank you.
Yeah, please come back because I learned a lot. This was great.
Thanks for your time.
Thank you so much.
Thank you.